everyone, and welcome back to my channel. Today we will be continuing our discussion of valvular heart diseases, and we will be proceeding forward with aortic regurgitation. In this video we will be talking about the causes, pathophysiology, signs and symptoms, examination findings, diagnosis, treatment, contraindications, and exam questions. So let's begin our discussion about aortic regurgitation. Like I previously mentioned, I will be teaching you from First Aid Step 2 CK book. So take out your books and let's start studying. So what is aortic regurgitation? This is the aortic valve, and it is between the left ventricle and the aorta. Aortic regurgitation happens when this valve becomes weak and blood cannot propel forward, and instead it trickles down back into the ventricle, causing the ventricle to hypertrophy. Let's discuss the pathophysiology behind aortic valve regurgitation. After systole, when most of the blood has gone into the aorta and to the rest of the body, the aorta has to act like a pump to propel blood forward. Instead, what happens that the aortic pump does not work and blood trickles down. That is one pathophysiology behind the blood trickling down. The second pathophysiology behind the blood trickling back is because the aortic valve might become leaky, and that will also cause the blood to backflow. Since this will occur during diastole, that is when the ventricle is passively filling, this will cause the aortic regurgitation murmur to be a diastolic murmur. Another thing you need to remember is that the murmur enhances when the left heart becomes bigger. What are a few causes that can cause the left heart to become bigger? These are a few of them. The left heart can become bigger when you increase the pressure or when you increase the volume. Increasing the pressure is by hand grip, which will increase the afterload, and leaning forward. Increasing the volume is by squatting and leg raise, which will increase the venous return from the body to the heart. And this will cause the heart to bigger and in turn the murmur to become more enhanced. There are also some maneuvers that can cause the heart to shrink and the murmur to depress. These maneuvers are Valsalva maneuver and giving the patient amyl nitrate, which will dilate the peripheral vessels and in turn cause the heart to shrink. Aortic regurgitation will cause left ventricular hypertrophy and left ventricular end diastolic volume, which means because the blood will be trickling down from the aorta into the ventricle during diastole, the volume of the left ventricle will increase during the end of diastole. One more thing that it will cause is the diastolic blood pressure will decrease. This will happen because of backflow of diastolic blood. Systolic blood pressure, however, will increase because the left ventricular hypertrophy will cause more blood to eject from the ventricle into the rest of the body, hence increasing the systolic blood pressure. Since the systolic blood pressure is increased and the diastolic blood pressure is decreased, that will cause a difference between the two, and this will result in an increased pulse pressure or wide pulse pressure. This was the pathophysiology behind aortic regurgitation. Now let's move on to the causes of aortic regurgitation. The causes can be acute and chronic, or we can also divide it into age-related causes. If the patient is over 50, the cause can be due to aortic root dilatation. Aortic root dilatation occurs because of increasing age, and it can also occur in patients with Marfan syndrome. What is aortic root dilatation? Let's suppose this is the normal aortic valve. You can see that this is a small valve and the cusps are closer together. But if the aorta stretches, it will cause the cusps to go further apart from each other, leaving a space, and it will cause the blood to regurgitate. And this aortic root dilatation is age-related, and it can also happen in people with Marfan syndrome. If the patient is below 50, the cause of aortic regurgitation can most probably be because of rheumatic heart disease or infectious endocarditis. They will cause weakening of the aortic valve. Some other causes can be syphilis, SLE, ankylosing spondylitis. How will a patient with aortic regurgitation present to you? So the first symptom that you need to look out for is syncope. Like aortic stenosis, this patient can also present with syncope. The reason behind this is because during diastole, blood is coming back into the ventricle, and this will cause decreased perfusion. Another thing you need to look out for is angina. The coronary arteries come out of the aorta and are perfused during diastole. If the blood is going back into the ventricle instead of moving forward, this will cause the perfusion pressure of the coronary arteries to drop, and in return it will cause angina. Another thing you need to keep in mind is that in these patients, tachycardia is well tolerated. The reason behind this is that since aortic regurgitation happens during diastole, this space will reduce during tachycardia, and that will allow less blood to regurgitate during diastole, and in return tachycardia will be well tolerated. Some of the acute symptoms can be rapid onset of pulmonary congestion. The reason behind this is that there will be excessive blood in the ventricles, which will propel back into the atria, and in return they will go back into the pulmonary system. That will cause pulmonary congestion. This in turn can cause cardiogenic shock and severe dyspnea. The cardiogenic shock will be because heart cannot pump enough blood forward, and the dyspnea will be because of pulmonary congestion. A person with chronic aortic regurgitation will have slowly progressive onset of dyspnea on exertion, orthopnea, and paroxysmal nocturnal dyspnea. While you're laying in your bed, the fluid will redistribute centrally, and that will cause pulmonary edema, and in return it will cause symptoms like orthopnea and paroxysmal nocturnal dyspnea. Along with that, there will be uncomfortable heart pounding while laying on your left. So these were the symptoms. Now let's talk about some physical findings that you will find while you're examining your patient. The first thing you need to keep an eye out for is the apical impulse will be displaced. Let's suppose this is your heart. Because of backflow of blood, there will be ventricular hypertrophy. Your ventricle will increase in size. That will cause your apical impulse to be displaced. There will be early blowing diastolic murmur at the left sternal border, and it will be heard better when the patient leans forward. Let's first concentrate on the early blowing diastolic murmur at the left sternal border. Aortic sounds are best heard at the second intercostal space, but when it comes to aortic regurgitation, it is best heard at the left sternal border in the fourth or fifth intercostal space. So why is that? Because the blood is regurgitating and it will hit the wall of the heart somewhere here. And that will cause the murmur of aortic regurgitation to be heard at the left sternal border in the fourth or fifth intercostal space. It will be a diastolic murmur heard between S2 and S1, and it will be a decrescendo murmur, which means that it will be decreasing in intensity from its start to the end. There will be also middiastolic rumble. Now what does that mean? So this is your aortic valve and this is your mitral valve. With regurgitation, what's going to happen is that the regurgitant blood is going to push on the leaflet of the mitral valve as well. And during diastole, we know that these leaflets will be open for the blood to go into the ventricle for passive filling. Now, when this blood is putting pressure on this leaflet, blood cannot go properly into the ventricles, and that will cause a mid-diastolic rumble. And this whole murmur is called Austin-Flint murmur. Like we had discussed earlier, the systolic pressure is increased and the diastolic pressure is decreased. And this increase and decrease and difference between the pressures will cause widened pulse pressure. And that can manifest itself in different ways. Some of the ways are as follows. The first thing is Corrigan sign, which, if heard in the femoral area, is called pistol shot sign. Another thing is known as de Rosius sign, which is going to be a diastolic bruit over the femoral artery. Third thing is head bobbing sign, also known as de Musset sign. In this, the patient will bob their heads with each heartbeat. Another sign is Quincke's pulse, which you can notice in your nail beds as blushing and blanching. So these were some of the physical findings that you will find in a patient with aortic regurgitation. Now, how will you diagnose a patient with aortic regurgitation? For best results, you should do echocardiography, which is the investigation of choice. Other than that, you can also do chest x-ray, but it's not going to be that specific. And the chest x-ray will show left ventricular enlargement. Along with that, it will show pulmonary congestion. You could also do left heart catheterization. Now, before we move on to the treatment, I want to discuss this graph with you guys. If you look at this graph, it's going fine till here, but after this point, it is dropping and dropping and dropping. The aortic pressure is not supposed to drop that much. Now, as you can see, this is the left ventricular pressure and this is the aortic pressure. The aortic pressure is supposed to go up after the start of diastole, but the aortic pressure drops instead because of regurgitant blood, and that is what's wrong with this graph. So if you get a graph like this between the left ventricular pressure and the aortic pressure, and if the aortic pressure is dropping, know that they're talking about aortic regurgitation. Now let's talk about the treatment options. In the olden times, they said that loop diuretics help tremendously, but nowadays, loop diuretics have little benefit. Nowadays, we prefer vasodilators like hydralazine, nitrates, dihydropyridine, or ACE inhibitors to help with reducing the afterload. These are vasodilators, and they will dilate the peripheral vessel, which will cause the afterload to decrease, and in turn will decrease the size of the heart. ACE inhibitors are particularly useful for patients with hypertension that also have a comorbidity of aortic regurgitation. If the symptoms become so severe and left ventricular decompensation occurs, which reduces the ejection fraction and in turn leads to congestive heart failure, valve replacement is required. The valves can be bioprosthetic valves or mechanical valves. If you're putting mechanical valves, you'll have to use anticoagulation therapy as well. At the end of the day, you need to monitor the patient, make sure that their left ventricular function and size is adequate. In aortic regurgitation, beta blockers are contraindicated. The reason behind that is beta blockers slow the heart rate, which in return decrease the already decreased diastolic pressure. That will increase the regurgitation, and the coronary artery hypoperfusion will happen, which will result in angina. This brings an end to the discussion of aortic regurgitation. Now, I would like to solve a question with you guys. Let's move on to the question. So, a 20-year-old woman. So, if you remember, we discussed causes from 50 plus and 50 and below 50. The causes above 50 was aortic root dilatation and Marfan syndrome. And the causes below 50 were rheumatic heart disease and some infections. Some other infectious cause. Since this patient is below 20, we could rule this in, okay? She reports no symptoms and her medical history includes no significant conditions. The patient has good exercise tolerance and does not take any medication or any illicit drugs. So good exercise tolerance, because if you remember, we said they have good tolerance for tachycardia. Her blood pressure is 125 by 65. So look at this, 125 by 65. The systolic pressure is high and the diastolic pressure is very low. So they have a widened pulse pressure. So that is one sign we discussed in aortic regurgitation. The pulse is 80 per minute. Cardiac auscultation reveals an early diastolic murmur at the left sternal border that is best heard with expiration. If you remember, I told you guys that the murmur of aortic regurgitation can be best heard at the left sternal border, and it will be a diastolic murmur. So they're talking about that. So that is one big sign. Carotid pulses are normal bilaterally and there is no bruit. ECG shows normal sinus rhythm without any significant abnormalities. What is the next best step in management of this patient? So if we do chest x-ray, let's suppose, the chest x-ray is going to show us left ventricular hypertrophy and pulmonary congestion, and that is not a very specific sign. It can be because of anything, so that we will cross out. This and this is usually done for people with suspected coronary artery diseases, and we're not suspecting coronary artery diseases. No further workup. No, further workup is necessary because we have a murmur. So if there's a murmur, we need to work on it further. We are going to choose echocardiography. Like I explained to you earlier, echocardiography is the investigation of choice for aortic regurgitation, and we are suspecting aortic regurgitation because of the early diastolic murmur at the left sternal border that is best heard with expiration. We also have this other sign, which is the wide pulse pressure, and that is why we will be doing echocardiography. So this is the end of discussion for aortic regurgitation, and I hope you learned something. I hope you enjoyed this video. Please share this video with your friends who might find this video helpful, and I will see you next time. Until then, take care of yourself. Bye.